this afternoon for our final installment of maximizing third-party reimbursement through enhanced medical documentation and coding. The first slide is just a disclaimer that gives you some tidbits about the presentation, and the information was, at the time presented, was error-free, and there have been some changes, and we'll discuss some of those changes at the very end of this presentation so that everyone's in the loop with the new regulations regarding the ICD-10 implementation. CPT disclaimer. The learning outcomes for this final installment will review CPT, HCPCS, and ICD-9 codes, which were learned in the first three series, Series 1, 2, and 3. And if you were not able to join for those webinar installments, please follow up at the very end of the presentation. There's some information that you can refer to so that you can gain access to the first three installments of the webinar series. In addition, there is a resource document that was created that also follows along with the 4 webinar series that was prepared for this presentation. So we'll look at quite a few coding scenarios, and we'll just recap some of the information that was covered in Series 1, 2, and 3. We'll also discuss the importance of, I'm sorry, I went ahead too fast. We'll also discuss the importance of proper code sequencing. We'll discuss the importance of proper documentation and its impact on reimbursement. So let's fix that. Some of the acronyms that's used in the presentation are on this slide and the next slide. So there's quite a few acronyms. So if we're on a slide that you're not, and we come across any acronyms that you're not familiar with, please feel free to refer back to these slides, and it will give you an overview. But I'll also mention those acronyms in case anyone needs some time to get those to get those acronyms. So in Webinar Series 1, we discussed evaluation and management codes and modifiers. So the codes on this slide are just an overview of the codes that we discussed in the installment 1. These codes are used to report new patient visits, and the code ranges are 99201 through 99205. The criteria that we discussed in installment 1 is that you require a history, an exam, and medical decision making. Time is not really a criteria. The exception would be if you're counseling a patient. And again, we will get into some further details about counseling as it relates to HIV and AIDS care and testing. The established patient visit codes are on this slide. The 99212 through 99215 are used to report services for a patient that has been seen by a physician and has been seen by a physician within a given specialty or practice within the last 3 years. And I believe we have a question. The acronyms are at the very beginning of the slides. So I will go back really quick so that you can see those. So if you refer to pages 8 through 11, you will have the complete set of acronyms that are used in the presentation.
Stacy, I just want to indicate to individuals that in the chat window, I have provided a link that individuals can download the presentation if they have not already done so. So please check that chat box for a link, and the PowerPoint will be available to you for download.
Okay, great. Thanks, Michael. CPT code 99211 is used in those instances where there's an order in the chart written by a physician, and the patient presents and they'll see a nurse for a very minor service, such as a PPD reading or screening or a vaccine or the HIV testing. So again, there has to be an order in the chart from the physician in order for an RN to perform the service and report the 99211. The codes on this slide, these codes are used for preventive medicine visits. So these codes are only used to reflect when a patient presents with no complaints, and they have, and so the term that's used to describe these codes, as we discussed in installment 1, are well visits. So these codes are used for your patients that are coming in for your well visits. Typically, your new patient well visit codes are used for patients whom have not seen a physician within the past 3 years. And then you have your established patient well visit codes. And these codes are used for patients that have been seen for a well visit encounter within the past 3 years. And keep in mind that these codes include the counseling component. So you should not be reporting any counseling service codes separately, because these are included in the preventive medicine visit codes. And there's a question on the floor: if using 99211 and the MD is not present, do you need a modifier? The answer to that question is no. The physician does not have to be physically present in the room. As long as there is a physician on site, that is acceptable. That is an acceptable use of CPT code 99211. Okay, so let's make sure. Oh, okay, so the person's comfortable with that answer. Okay. The selection of the preventive medicine visit codes is based upon the patient's age. So as you can see, oops, sorry about that. So as you can see, the 99381 and the 99391 are both based on the patient's age younger than 1 year. And since we're dealing with mostly adult patients, I'll skip down to the adult patient codes. So your 99386 and your 99396 are based on patients that are receiving preventive care between the ages of 40 to 64 years. This slide provides the preventive medicine counseling visit codes. So these codes are only used when there is just counseling that does not include any history or any physical exam. So these codes are appropriate for counseling and also risk factor intervention visits. And as you can see, these codes are reported on the basis of how much time is spent with a patient. So 99401 is a 15-minute counseling visit versus your 99402, which is 30 minutes. And then you have your 99403, which is 45 minutes, and 994, I'm sorry, this is an error which I forgot to correct, and I apologize. The last code is supposed to be 99404, and that's 60 minutes, which is typically not typically used because most of the times the counseling component doesn't really take that much time. But just so that you know, the code 99404 is 99404 is for counseling that comprises of 60 minutes of face-to-face care. All of the codes in these slides are specific to face-to-face care, with the exception of the 99211, which we said did not require the presence of a medical doctor in the physical exam room. As long as the MD is on site somewhere in the event of an emergency, it is appropriate to use that code. And we have another question. Can 99401 and other codes be used by a nurse or mid-level practitioner without an MD in the room? It depends on the advice and guidance by your local state Medicaid agencies and as well as your insurance carriers. So I would say to you that you should follow up with the insurance carriers that you participate in. It's very important that you follow up with these entities prior to submitting these codes, because in some states They want you to report the preventive medicine visit counseling codes for counseling services, and in some states they want you to report the regular E&M visit codes, which would be the established patient visits when a patient presents for any counseling. So it all depends. In installment 2, we spoke about the service codes, and by service codes I mean the test codes that are used to report HIV testing. And there are 2 types of codes. You have your CPT codes, and you also have your HCPCS codes. For the most part, the CPT codes are numeric, so that would be the distinction between a CPT versus a HCPCS. Your HCPCS codes all begin with an alpha, and so in the case of the HIV-1 single result test, as you can see, the code begins with the letter G. So G0435 is the code that is the HCPCS code that describes the HIV-1 test, and CPT code 86701 is the code that's used to describe the same type of test. Now, if you're performing any rapid tests, the codes that are described in this slide, these are the codes that are typically used to report the rapid tests. And so I provided for you some examples. OraSure Technology, Alere Determine, Trinity Biotech Unigold. These are the typical code, tests that are used, that are performed in conjunction with the codes that are reflected on the slide. And typically, a test is reimbursable every 6 months, but again, you should follow up with your carriers because they may have some different guidance in place. Some may say every 3 months, some may say every 9 months. Typically, it's every 6 months. The code for blood draw is on this slide, 36415. If you decide to do blood work instead, in lieu of rapid tests, then you would use CPT 36415 in addition to one of the office visit codes. So your established patient visit code, along with the code for the routine venipuncture. And we'll look at some very specific examples in a moment so that you can see how those will be reported on your claims. Here are some additional codes, and so again, this is for the antigen for the HIV infection. So you have your CPT codes, and you also have your HCPCS codes. Modifiers was discussed in installments 1 and 2. There are 2 types of modifiers. Well, let's start with what modifiers are. The modifiers are used to indicate that a procedure or service has been altered by a specific circumstance, but there has not been a change in the definition of that modifier. For the purposes of reporting, there are CPT modifiers and there are HCPCS modifiers. A lot of the times you have modifiers that impact your reimbursement. Modifiers are never reported alone, so this is not something that you would report on a claim without a CPT code that describes the service. Modifiers are never appended to the diagnosis codes, and in order to ensure that you're utilizing the most appropriate modifier and that it doesn't impact your reimbursement, you should follow up with your local Medicaid agency, and they will provide you with a list of the approved modifiers for the services in your state. This goes for your insurance carriers as well. Follow up with your insurance carriers, and they will inform you of the modifiers that are approved for their services. So the first type of modifier is modifier 25. This modifier is typically reported on CPT codes only, but there are some HCPCS codes that the modifier 25 is appended to. So even though this says do not report with HCPCS codes, the coding guidelines state that you can't report it with HCPCS codes, but there are some payers that allow you to append modifier 25, and I apologize, I didn't mean to cross that out. There are some payers that have given specific instructions to use the modifier 25 on a HCPCS code and on an E&M code. So you have to follow up with those payers before you begin using the modifiers. Another modifier that's used specific to the test, the HIV test, is modifier 92. There's another modifier that we're going to discuss in a moment, but modifier 92 is alternative laboratory platform testing, and this modifier is only used to report past lab tests. Here are the code ranges for the tests that are typically used in conjunction with the modifier 92. This modifier is never reported with any other code type. So this would never be appended to your E&M codes. And let me just go back really quickly to that slide so that you could see which codes I'm referring to. Page 14. Sorry about that. So the modifier 92 is never appended to any of the E&M codes that are reflected on slides 12 through 14. Through 15. They're only appended to the HIV test codes. The second modifier that is similar to the modifier 92 is modifier QW. Modifier QW, the modifier QW is a clear wave test, and it's similar to modifier 92 in that it's never reported on any other code type except for path lab. So again, here are the test codes that modifier QW is appropriate to append. It's never appended to any other type of test. And in those instances where you are performing multiple tests, so if there's a wave test and a non-wave test, then modifier QW should not be used. So you have to determine which tests are designated as clear wave. And if you go on the FDA's website, you can get a very comprehensive list of all of the clear wave tests, so you'll know which ones are appropriate with modifier QW. You should contact your local Medicaid agency to find out if you should be utilizing modifier QW or if you should be utilizing modifier 92, because again, it varies from state to state. The diagnoses codes was discussed in installment 3. So this slide provides you a short list of the most commonly used modifiers that reflect services that are reported for patients that are coming in for HIV testing. I included the well visit modifier, I'm sorry, calling this a modifier. I included the well visit diagnosis code on this slide because oftentimes patients come in for a well visit, and as part of the well visit encounter, the physician may make the decision to perform an HIV test, screen, or perform counseling. So this code is limited to a well visit encounter only. You would never report this for any other type of service. And typically with the well visits, for a patient that presents for a well visit for the first time, you would use the V70 in conjunction with the well visit preventive care codes that we discussed on slide 14. Let me just go back real quick so that everyone can see those codes. So the V70 was reported with these codes, V70.0. I apologize, I'm trying to write with this. So the V70 diagnosis code is only reported with the preventive medicine visit codes. In those instances when a patient returns for the follow-up well visit encounter, you would utilize the V70 code for those instances as well. Now, there are going to be some occasions where patients come in for just the test, and in that case, this is not considered a well visit, and you would not use the well visit code. So this diagnosis code is only reported when a patient is coming in for a well visit. You can report other diagnosis codes, but the well visit code in this instance should be sequenced as the principal diagnosis. Because there was some confusion in installment 3 when we discussed diagnoses, I felt it was important to go back and pull the code book excerpts. So what we did for this installment is we added the language that's in the ICD-9 code book for the diagnosis code of 042, which is the AIDS disease, infection, and here are the common terms that are used to describe the diagnosis code that ties in to treatment or care for a patient that's diagnosed with the condition. So I wanted to make sure that I put this specific information so that providers would know what information a coder looks for when we're abstracting a record. When we're abstracting a record, if the medical record says something specific to HIV positive or asymptomatic HIV, the diagnosis V08 is what the coder is going to pick up. But if the documentation states any of the terminology that's here on this slide, then this is the diagnosis code that the coder is going to select for that scenario. And additional information that's in the coding book states that if the patient has any manifestations or any complications of HIV or AIDS, that those conditions are also coded. So in situations where a patient has been formally diagnosed and they have advanced stages of AIDS and they have other medical conditions, the diagnosis of 042 would be sequenced first, and all of the manifestation conditions would also be reported, but those would be reported as second, third, depending on what's documented in the medical record. Additional coding instructions that's in the book state that if the patient is diagnosed with HIV-2 infection, that this additional code should be reported. And so I have some very specific examples when we get to the coding scenarios, so that you can see how that is reflected in your billing and when you're submitting the encounters to the payer. Also in the code book is an exclude note, or rather I should say an excludes note. And the exclude note says that if the documentation states that a patient has a symptomatic HIV infection or infection status, that you code it as V08. If it's an exposure to, then it's coded as V01.79. And, or if it's a non-specific test result, it's coded as 795.71. So I hope that this information clears up any confusion from installment 3. And we will be going back to installment 3 and adding the additional slides so that you'll have those for your own personal use. But what I recommend is that if you have access to a code book, that you take the time to review the coding guidelines that are specific to how to report HIV and AIDS. We've also included that on the slide, and we'll get to that in a moment. So we just discussed the V08, and we mentioned that the V08 diagnosis code reflects HIV status. And so anytime the documentation from a provider in a medical record states that the patient is HIV positive or that they have a symptomatic HIV, the coder is going to pick that up as V08. And as you can see, this diagnosis code is very different from diagnosis code 042. One states that the patient has the condition, AIDS, HIV disease, or HIV infection, and the other one, V08, implies that this is HIV positive or it's asymptomatic. So some notes that are also included in the code book. The first note says this code is only to be used when no infection symptoms or conditions are present. So we have to make sure that we are all clear and understand that the V08 is a patient who presents, the provider has not definitively diagnosed them with the HIV infection, but that they have symptoms, that they have no symptoms. And now if the condition if the documentation states that there are symptoms or the patient has some other pre-existing infections that are a manifestation of AIDS, then the coder is going to pick up 042. Some additional excludes notes that tie into diagnosis code V08. If the patient's documentation states that they have AIDS or acquired immunodeficiency syndrome, the coder is going to pick the code up 042. It applies to this also. So these are the three scenarios where the coder is going to pick up 042 instead of V08. And as coders, our diagnosis code book is like our coding Bible, and we follow the coding guidelines to the letter of the law. So we want, in order to make sure that we are properly coding patient records, the documentation needs to be very clear and concise, and it has to clearly state what the patient's condition is. And if there's any inconsistencies, a coder is going to go back and query the provider. But we're not going to just arbitrarily presume that the patient has the condition unless the documentation clearly states so. The next code that we added to the slide from the code book is nonspecific serologic evidence of HIV, and a pseudonym for this is inconclusive HIV test in adults and in infants. So if the test is performed and it's inconclusive, the final diagnosis that a coder is going to pick up is 795.71. And again, here's a note that's pulled right from the code book. This code is only to be used when a test finding is reported as nonspecific. Asymptomatic positive findings are coded to V08. If an HIV infection symptom or condition is present, it's going to be coded to 042. The last statement in the book was negative findings are not coded. So if the condition is stated as negative, there's not going to be a code in accordance to the coding guidelines. And I believe there was a question. So the question on the floor is I have had doctors diagnose HIV positive and the documentation and document an infection that is directly related to AIDS but refuses to diagnose AIDS. That's a hard one. Here's how I would answer the question. If you work in a facility and the facility has a policy in place that allows or requires the coders to code from the medical record, then you would code exactly what's documented in the chart. So if the patient has an HIV-related condition or other infections or manifestations, and your facility has in place a policy that states that the coders are coding the records, then you code exactly what's in the record. So you would code the HIV condition, 042, and you would code any of those manifestations. If there's no policy in place, unfortunately, you're going to have to bite the bullet and code it as V08. Or another suggestion I could give is that you would speak to your supervisor and explain to them that the coding guidelines state what we just covered as far as what the coding guidelines are, and maybe your supervisor could perhaps speak to the physician to see if they would appropriately document so that you can appropriately code. Because believe it or not, we are now in a day and age where we get paid, or rather I should say we are reimbursed based on how sick patients are and how well their care is managed. And this is especially important for patients that have multiple chronic conditions. So if your provider is not willing to code the encounter appropriately, in essence, they're losing revenue. So that might be something also that you can use to kind of get the doctor to code appropriately, that we're losing revenue because the codes are not correct. All right. 795.71, additional excludes. So again, it says it excludes AIDS, it excludes the HIV infection symptomatic. So these are all exclude notes that are referenced in the code book for 795.71. And so for those of you that are not really involved in the coding process, excludes means that if the documentation clearly states any of the diagnoses that are under the exclude section, that we are not going to assign this code, but instead we're going to assign one of these codes on the basis of whatever is documented in the record. Let's see, I think I see another code here, another question. For the diagnosis code 079.53, we have providers that bill that as the primary. Is that okay? And the answer to that is no. And let's go back. I kind of skipped over this, so now that the question is coming up, I'm going to address it. The coding guidelines state that if a patient is diagnosed with HIV-2, the correct way to report that, let me just get rid of all of this so that we can see. So the coding guidelines clearly state that if a patient's chart denotes the HIV-2 infection, you have to report two different codes. So the principal diagnosis in this case would be 042, and the secondary diagnosis code in this case would be 079.53. So to answer your question, 079.53 is never reported as the only code for a patient that is a diagnosis of HIV-2, and it's never sequenced as the principal diagnosis. The principal would be the 042, and the secondary would be 079.53. All right. I also went back and provided some additional information. Again, as a coder, we are required to follow the official coding guidelines. So I provided in some information for you regarding the official coding guidelines. So anytime the documentation states any of the statements here on this slide, as a coder, the final diagnosis that we're going to select is 042. And I believe there's another question. Once 042 is diagnosed, can VO8 ever be used? And the answer to that is no, so I'm going to go back. So the question on the floor was pertaining to a patient who's been diagnosed with AIDS. Once a patient has a diagnosis of AIDS, this is the diagnosis that will follow them. It's going to be the diagnosis that should be reported. It's going to always be their diagnosis. The diagnosis of V08 would never be used once there's a confirmed diagnosis of AIDS. I hope that answers the question. And I also have some information in some slides that we're going to be looking at down the line before we end the presentation. And so the official coding guidelines, I thought it was important that as a coder, since we have a lot of clinicians on the call, that the clinicians understand how us coders think. We understand how clinicians think, but now we want to be able to have the clinicians and doctors understand what we're up against as coders. So again, in the code book, the coding guidelines state that we're only allowed to code confirmed cases, and a confirmed case would get a diagnosis of 042. And in some documentation that I've read, doctors indicate probable, suspected, suspicion of, and according to the coding guidelines, that's not considered a confirmed case. So we would not report the diagnosis of 042 unless there is very clear, specific documentation that states that this is a confirmed case or a confirmed encounter for a patient who has AIDS or HIV infection. There's some additional coding guidelines that were added to the slides. So, and please disregard the term admission. It's used in the context of admitted to the hospital, checked in to outpatient clinic as far as a patient coming in for a follow-up encounter. So if a patient is admitted for an HIV-related condition, the principal diagnosis should always be 042, which we just discussed. And then you would report any additional diagnoses that are related, HIV-related. And the resource document that was created provides the summary of all of the diagnosis codes for most of the commonly reported HIV-related conditions. There's a long laundry list, and that list can be found on the Centers for Disease Control's website. But in the interest of time, we pulled together just the most common ones, and we'll see those in a moment. Another guideline that speaks to the asymptomatic or infection status, or HIV positive. V08 says a symptomatic human immunodeficiency virus infection is to be applied when the patient without any documented symptoms is listed as being HIV positive. So anytime the documentation states HIV positive, known HIV, HIV test positive, or any similar terminology as a coder, we're going to code that as V08. So again, it's very important that the providers on the line understand the importance of properly documenting so that we as coders can make sure that we are properly coding the services that you're reporting. Let's make sure there are no other questions. I think there's another question here. I work in an outpatient clinic. All of the patients seen are seen for HIV as primary. Should our providers use the 042 as a primary code and any other diagnoses as additional? So the answer to that would be the reason for the encounter. Let me go back, I'm sorry. If a patient presents for treatment of that condition, of that HIV infection or that condition, that would be sequenced as the principal diagnosis. The patient just so happens to have other conditions such as diabetes, hypertension, and again, I have some slides. I did put something on to give some clarity because I presumed the question would come up on the call today. I put together a PowerPoint to discuss that. If a patient comes in and if the patient comes in and they're being treated for the HIV infection, and they just so happen to have other medical problems that the doctor will address, the principal diagnosis is going to be the AIDS. On the flip side, if a patient presents and they're being evaluated and treated for diabetes, hypertension, or some other chronic condition, or some other acute problem, and the doctor also addresses their HIV condition, but that's not the reason for the encounter, then the diagnosis that reflects the reason for the encounter, diabetes, hypertension, asthma, or whatever the case may be, that would be the principal diagnosis, and the AIDS condition code would be the secondary diagnosis. All right. Okay. Patients with inconclusive HIV serology. So again, this is an inconclusive test. The coding guidelines state patients with inconclusive HIV serology but no definitive diagnosis or manifestations of the illness are assigned 795.71. All right. Previously diagnosed HIV-related conditions. So patients with any known prior diagnosis of an HIV-related condition or illness should be coded as 042. Once a patient has developed an HIV-related illness, the patient should always be assigned code 042. I think this question came up. So this is the answer to your question. As you can see, this is in black and white in the coding guidelines that us coders follow. So this really should bring the point home of the importance of documentation, so that as a coder we will be able to appropriately assign the codes for the services that's documented, and that we get reimbursed properly, because again, the diagnoses tie into our reimbursement. So just to reiterate, patients with a known prior diagnosis of an HIV-related illness should be coded as 042. Once the patient has developed an HIV-related illness, the patient should always be assigned 042 on every subsequent admission or every subsequent encounter to the doctor's office. Keep in mind, however, the inpatient coding guidelines state that a coder has the flexibility, and they can go in to a chart, and if the documentation from a prior visit says that the patient has AIDS, they're going to code it as such. But on the outpatient side, if the doctor does not clearly state that the patient has the condition, typically the coding guidelines tell us to defer to V08. However, a patient, sometimes coders are allowed to review other components of their medical record. So for example, we may use the lab results. If the lab results show that the patient has a CD4 count that meets the criteria for this condition, we're going to use the lab results. If the patient's chart denotes that the physician prescribed prescriptions for treatment or care related to HIV, we may use that information. But in the absence of any policy that a facility may have in place, a coder may not have such flexibility. So it's important that the specific conditions that are treated are documented in the medical record. Another coding guideline, encounters for testing. So if a patient is being seen to determine his or her status, the code that we're going to report is V73.89. This code reflects screening. All right, there are some other diagnosis codes that were referenced in the policy, so I included that information for your convenience. Use code V69.8 for other problems related to lifestyle. This code is never used as the principal code. It would follow the screening code V73.89. Another code that is important to remember is the code for counseling, V65.44. The second paragraph says that when a patient returns to being informed of their results, that you should use the counseling code. So again, once you do the test, if you're doing the blood test where you're having the patients come back for the results, the code that you should be reporting is V65.44. If you're doing the rapid, then you should be using V73.89. Oh, sorry. Should be using V73.89 and V65.44, because during that particular encounter where you're going to be doing the screening, you will have counseled the patient. So in those settings, in that particular scenario, you would use both codes. We spoke about the stages of the HIV infection in installment 3, so I'm not going to go through any of these. We spoke about also opportunistic infections and the 4 types. And so here are some of the most common opportunistic infections. And so again, if a patient has any of the common opportunistic infections that are associated with AIDS, then you're going to assign the principal diagnosis as AIDS, along with the diagnosis code for any of the opportunistic infections that are noted here on the slide. We covered this in PowerPoint Series 3, so I just want to make sure that we have enough time to go through the coding scenarios. So I put together this list of some of the most common opportunistic infections. So again, if you go to the resource document that was created, the codes for these specific opportunistic infections are found in that resource document. If you want the complete list of all of the opportunistic infections that coincide with patients that have AIDS, please visit the CDC's website. And at the very end of the presentation, all of the resources that were used in the presentation are on a slide. You can access those by clicking on the applicable links. Inconclusive HIV tests is commonly reported for those services where the physician is not able to determine the patient's status. I put this slide together to specifically address the newborn babies that are born to HIV-positive moms. Typically what happens, a diagnosis of HIV-positive in a baby is as a result of the mother's antibody status. And the diagnosis of HIV-positive typically lasts up to 18 months. So in those instances where you have a newborn baby that's born to a mom that's HIV-positive, the results may end up as a false positive. So the diagnosis code that has been dedicated for this scenario is under the category of inconclusive HIV test, and the code is 795.71. So now let's look at the coding scenarios. We have about 10 of those, and the presentation, the coding scenarios bring together all of the codes that were discussed in installments 1, 2, and 3. So the case studies are going to be similar, and the only difference is now you'll get to see the CPT code together with the diagnosis code. So this is a counseling, an HIV counseling without testing. The patient presents to her GYN to discuss contraceptive options. And I forgot to put the code for the contraceptive options, so I apologize for that, because this PowerPoint series really was dedicated to the treatment of and counseling for HIV, HIV and AIDS care, so I forgot a code. This is a patient that comes in for a GYN, and the doctor counsels the patient, and they discuss various methods. And the physician was able to convince the patient to take a test, and the patient agreed, but then later declined. So the physician in this encounter billed the 30 minutes of counseling, and the diagnosis code that's here reflects counseling, and the CPT code that's here is for counseling. And if we go back to slide 15. So we indicated that the counseling codes where there's no history and no physical, the correct code to be reported would be one of the counseling codes. And so if a patient, so in that example that I'm going to go back to really quickly, so in this example, the encounter states that the physician spent 30 minutes counseling the patient, and that's the only service that was provided. So the CPT code would be 99402. The next slide gives you the rationale. Patient presents for counseling. There is no distinction between new versus established with the counseling codes. So the correct code in this instance is 99402. There was no mention of any preventive care. This was just purely counseling. And if you notice, we indicate that the diagnosis code for counseling is V65.44. So this encounter is complete. There's no need for any modifiers. Your CPT code represents 30 minutes of counseling. Your diagnosis code reflects counseling. And I think there's a question. What disciplines can bill for HIV counseling? MDs, license. What you really should do is check with your local Medicaid state agency, because in some states it may vary. But your MDs, your licensed social workers, your NPs and PAs, but again, it all depends on your state. So you should follow up with your local state Medicaid agency and any of the carriers that you participate in, and they'll give you specific guidance on who can bill for the services and who can't bill for the services. This is a scenario where the patient had a rapid HIV test and they also had preventive care. So a 27-year-old patient presents to the primary care's office, recently concerned about having unprotected sex, and they request an HIV test. This is a new patient, and the physician does a preventive exam and spends 15 minutes counseling the patient. A rapid HIV test is also done. So here are the two CPT codes. And in this encounter, if you'll notice, there's a modifier. Excuse me. The reason for the modifier is because another service, the modifier 25, says that during an E&M encounter, another service was performed. So here's the other service. And in this particular section, the 86701 is the code for the rapid HIV test. And according to the coding guidelines, you would need to also append a modifier 92 or the modifier QW. So you should check with your local Medicaid agencies and your insurance carriers to find out which which modifier should be used. So here in New York and New Jersey, we're using modifier QW, but in other states, they may be using modifier 92. You might get instructions not to use a modifier at all. So again, the presentation follows the coding guidelines. You have to follow specifically what your payer tells you if you want your services to get paid. Here are all of the diagnoses that tie into the services. So your preventive medicine visit diagnoses, as we discussed earlier, V70.0 is the diagnosis code for preventive medicine visit. The V73.89 is the screening code. You have the counseling code, and you don't necessarily need the code for high-risk behavior, but it's there nonetheless because the documentation says that the patient had unprotected sex. The diagnosis codes that were linked to the rapid tests are V73.89, V65.44, and V69.2. Now, if your carrier advises you to report V70.0 as the principal for your rapid test, then that would be the instructions that you should follow. But again, the diagnoses that you report should coincide with the reason for the test or the reason for the visit. And so if your payer deems V70 as not applicable for this test, then you should not be reporting it. And I think a question came up. We are in the process of starting HIV screening and testing. The testing screening will be done by a nurse. Does the physician need to see the patient as well in order to bill the test? So, as I indicated previously, in order for the nurse to do any screening, or rather I should say any counseling or testing, there has to be an order in the chart. And in order for there to be an order, that means the physician would have to see the patient. So yes, you would need a physician order. The patient would need to see the physician prior to seeing the RN. Here's the rationale for this scenario. So this is a general medical exam, also known as a well visit. So we use the 99385 because this was a new patient visit. We also mentioned on the preventive medicine slides that counseling is included in preventive care, so you should not be reporting counseling services separately. The medical record states that this is an HIV rapid test, and because this is a point of care test, the provider would also report 86701. We use the modifier 25 for the well visit, and we are going to append either QC or 92, depending upon your guidance from your payer. I believe there's another question here. Is it proper to list a V code as the primary diagnosis? Absolutely, depending on what the V code that you are sequencing is. So let's go back to the diagnoses. Let's see, 39. I'm going to go back to the diagnosis slides real quick. I believe the diagnosis slides was 11. Okay. Nope, I apologize. It's not the right slide. 22. Okay. Let me get rid of all of this stuff here. So on this slide, you have more V codes than any other type of code. The V70.0 is the diagnosis code that designates that this is a well-visit encounter, and the well-visit encounter, the well-visit diagnosis code is only used in the outpatient setting and is always typically the principal diagnosis for a well-visit encounter when it's paired up with the well-visit CPT codes. So if you go back to 22, if you go back to slide 14, I believe it is. So these are your preventive medicine visit E&M service codes, and typically the principal diagnosis is always going to be V70.0. Most of the times what a payer will do, if you have another diagnosis code as the principal, they'll deny the service because the well-visit codes imply that the patient has no complaints and that they're there for a well-visit screen. So when you report any of the E&M codes on this slide, your principal diagnosis should always be V70.0. All right, let's go back. So the V67.9, the V69.2, and the V69.8 are oftentimes reported as the secondary. In fact, this code has coding guidelines that state it's only reported as the secondary. So on this slide, the codes that are typically reported as a principal diagnosis are the V70.0, the V08, the V65.44 is a code that's sometimes reported as principal, and sometimes V01.9. These three codes are typically reported as a secondary, meaning that it should be sequenced as the second code where there are other codes, second or third. It could be depending on what other diagnosis codes are reported for that service. I think there was another question, or is it the same question? Oh, okay, so we're good. So I'm going to go back to where we were. So to recap, a rapid HIV test with preventive care, new patient encounter, new patient E&M. Patient also had a rapid test. So you need your E&M, you need your rapid test, which is here, and your modifier 25 is appended to the E&M. Your modifier 92 or modifier QC is appended to the test code. Let me get rid of all of this. Continuation of this rationale for this case study. So you have your diagnosis codes. So this is a well-visit encounter. V70.0 is the principal diagnosis. The physician did a screening, an HIV screening test, V73.89. Counseling was done during that encounter, V65.44. The diagnosis of high risk or unprotected sex, V69.2. So again, The first three codes, V70.0, V73.89, and V65.44, these should definitively be on this encounter. The V69.2 is optional. It's more for statistical purposes. You have some entities, they like to, track data. So this is not mandatory, the V69.2, but I would say you should report it because this also helps facilities to determine how much money is needed for how much money and resources are needed for treatment of the patients in your catchment area. All right, the next case study is the same, so I'm not going to go over all of them. This is an established patient. The diagnosis codes are the same. The test code is the same. The only difference is that this is an established patient visit code. HIV testing with counseling. So, again, a patient comes in, they're concerned about having unprotected sex. The physician counsels the patient for 35 minutes. There's blood work drawn, and the specimen is sent to the lab for processing. Now, even though the case study says that this is an established patient, that's important, but in this instance, because we used the counseling code, for right now it's not important, but if your local Medicare carrier, your local Medicaid carrier tells you not to use these, that's where the designation of established patient is very important. So for the purposes of this being a counseling service, and for the purposes of a local Medicaid agency that tells you to utilize the counseling codes, 99402 was reported for this encounter. The modifier 25 was used because there was some blood work, and here are your diagnoses that reflect the service. V73.89 for screening, V65.44 for the counseling, and V69.2 for the high-risk behavior. The modifier 25, really and truly you should check with your local Medicaid agency because in the case of the counseling, they may or may not advise you to use this modifier. So some payers will tell you you don't need the modifier. Some payers will tell you that you do need the modifier. The rationale for this case study: counseling based on time. So the patient was counseled for 35 minutes, and the counseling code was selected on the basis of how much time was spent counseling the patient. The physician made the decision to perform a rapid screen test, and they have an on-site lab that processes this service. Since there is an on-site lab and the specimen was sent to the pathologist to process, the case study here, if you notice, we did not use the rapid code. And the reason why is because the provider drew blood and sent the specimen to the on-site lab. Someone's asking the question about the comparison of reimbursement, and unfortunately I don't have any comparative data, but what you could do is you can, I'm not really sure how it is from state to state, but in the 2 states where I have a few clients, you can go online to your local Medicaid agency and they'll provide you the fee schedule, and you will be able to get the actual reimbursement for all of the services that are performed in your facility, and then you can run comparative data that will be helpful for you in tracking resources and services for your facility. The diagnosis codes we discussed again: special screening, V73.89, counseling, V65.44, and high risk, V69.2. Again, so this example is similar to the one we just looked at. The difference is for this particular scenario, the payer advises the physicians to use the E&M codes instead of the counseling codes. So again, you really should check with your payers, depending on the type of services that you're performing, before you submit claims. If your services are being denied, you can contact your payers, and they'll clearly explain to you the reason for the denial, and they should also be able to give you some guidance on how to correct that denial. So in this encounter, it's the same exact scenario as the case study number 4. The difference is the payer advises that the physician should use the established patient visit codes. So patient was counseled for 10 minutes. This is an established patient. Bloods were drawn, and the diagnoses changed a little. Patient is HIV positive, so the diagnosis V08. They were counseled, V65.44, and this one's asymptomatic high-risk lifestyle, V69.8. Blood work was drawn, so we used the CPT code for the blood work, and the rationale is here on this slide for you. Expanded problem-focused history with a brief exam was documented in the record. That's the reason for the E&M code in this particular case, 99213. We've put on this slide that you can only bill for point-of-care tests, and since this one was an on-site service where they did blood work and sent it down to the lab, we're not billing for a rapid test in this scenario. We're just billing for the E&M level and the blood work that was drawn. The next slide just gives you the rationale for the diagnoses. Documentation states that the patient is HIV positive. They have counseled the patient, and they also have a history of IV drug use. So that's your V69.8. The question on the floor, can we use ICD-9 code for all HIV? So to answer that question, we're going to go back to the diagnosis slide. And the slide number 22, give me 1 second, let's go back there. And let's get rid of all of this. Okay, so the two codes in question are 042 and V08. So when a patient's documentation states that they have AIDS, HIV infection, HIV disease, the principal diagnosis, the diagnosis is going to be 042. When the documentation states that the patient has asymptomatic HIV status, HIV positive or HIV positive status, the code now is V08. So you really want to make sure that the documentation is clear so that you can report the most appropriate code for that patient encounter. I hope that answers your question. Let's go back. Alrighty. The next scenario. So this is a scenario where the patient is coming back for counseling and their results are negative. And so if you remember from the coding guidelines that we were reading, there is no diagnosis for a patient who presents for negative results, but you're still counseling the patient nonetheless. So since there was counseling involved, 30 minutes of counseling is coded. The diagnosis code for counseling is here, and high-risk behavior is also here. So this scenario is pretty straightforward, and here is the rationale for this scenario. Patient returned for their results. The results are negative, but the provider counseled the patient, so that's really what we're billing for in this encounter. We're billing for the counseling, not so much the fact that the patient's diagnosis is negative. You really want to make sure, though, that your documentation clearly states that the results are negative. That the results are negative, but your the important aspect here is that you counsel the patient, and that's why you're billing for a diagnosis code of counseling. We also indicate the diagnosis code for the safe sex, discussion about the safe sex V69.2. So your two diagnoses are explained in this rationale here. The same scenario, but now the patient's diagnosis is that they're HIV positive. So patient returns for their results. The physician informs the patient that they're HIV positive. The physician counsels the patient. They discuss the importance of safe sex. Prescriptions are given, and the physician also gives the patient some HIV education. There's a treatment plan that's prepared, and because this is an established patient, the doctor documents an expanded problem-focused history with low medical decision-making. So that the E&M level in this case is 99213. The reason why this is a definitive E&M code of 99213 is because the patient has a confirmed diagnosis of HIV positive. So the diagnosis, along with the prescriptions and the counseling, qualifies this as a V08 as the principal diagnosis, which I think someone asked about in one of the questions with regards to reporting V code as the principal diagnosis. Secondary diagnosis is counseling. The documentation states that the patient was counseled, so that is very clear and plain. Okay. Here's the rationale. I'm not going to go through this in detail because we are running out of time. The diagnoses. So we explain why V08 is the principal and V65.44 is the secondary. This is another scenario, and again, it's similar to the previous one. The only difference is this patient has the diagnosis, and they are diagnosed with the infection. So 042 is the principal diagnosis. V65.44 is the secondary diagnosis. The same course of treatment was taken, or the same treatment plan and action was taken. There was counseling. There was a discussion about safe sex. The education materials was distributed. A treatment plan was documented. So this is the same scenario. The diagnosis code was the only thing that changed. So here's the rationale that describes the E&M encounter. And here's your diagnosis code rationale. This scenario describes a patient that has been diagnosed with the HIV-2 infection. So something that we didn't have on the prior slides when we did the webinar series 3 is that the HIV-2 infection is prevalent in West Africa. It's not typically something that's diagnosed here in the United States. So in this particular scenario, it was important to note that the documentation stated that the patient recently relocated to the U.S. from West Africa. So in this encounter, the patient's principal diagnosis is 042. Their secondary diagnosis is 079.53, which depicts the HIV-2 infection. And there was counseling, so the third diagnosis is V65.44. And I'm going to skip right to the ICD-9 slide, which gives you the rationale for the three diagnoses. The coding guidelines state that anytime a patient has the HIV-2 infection, the principal diagnosis is always going to be 042, followed by 079.53. The physician counseled the patient, so we also include the counseling code for the scenario. Our last case study is antiretroviral therapy for a newborn patient. An HIV-positive mom brings their baby to the 2-month-old to the pediatrician's office. The physician documents an expanded problem-focused history and does a brief exam. The labs were reviewed, and the physician decides to modify the medication, and the patient is advised to bring the baby back in 1 month. The medical decision making is low in this encounter, so the E&M level is 99213. We discussed that for newborn babies, their status is, their lab results are going to be HIV positive, but it's because of the mom's antibody status. So the principal diagnosis is 795.71. The diagnosis code for contact with or exposure to V01.79 is included. And let's just take a quick moment to go back to the diagnosis slide. Oops, sorry about that. Go back to your diagnosis slide so that you can see what the diagnosis is, the diagnosis description is, contact with or exposure to, and also pre-exposure prophylaxis. So in this case, because the newborn was exposed to the mom's antibody status, is the reason why we're using as the second diagnosis V01.79. Here's your rationale. Let me just go back real quick. I'm sorry. Oops. Here's your rationale. The mom presents. This is considered a sick visit encounter. The documentation states that labs were reviewed, medication was dispensed, and the 99213 is the final CPT code for this encounter. Here's the diagnosis rationale. This is a false positive. The results are inconclusive, 795.71, and V01.79. So our closing comments. If you're still using paper chart, it's suggested that you use standard medical abbreviations. It's important that the use of the up and down arrow symbols is not used, because oftentimes as a coder, we misinterpret that to mean hyper or hypo. So instead of using those up and down arrows, we would prefer, if you're trying to tell us that the patient has hypertension, that you can use the abbreviation HTN, but the up arrow, if you document in the chart the up arrow with BP, we're going to assume and interpret that to mean that the patient has elevated blood pressure, which is different from hypertension. All right. Medical conditions under physician care must be clear and concise so that we can code those for you. Each visit documented in the medical record must be able to stand alone. If, as a provider, you're documenting see prior note, an auditor may come in and they're not going to toggle between visits. When we look at our medical record, we expect that whatever services or whatever treatment was rendered to the patient is clearly denoted and clearly reflected in that particular encounter. Chronic conditions documented in a note must be redocumented in every encounter. Documentation which states see prior note, which we just said is considered unacceptable. Problem list. So the problem list is the provider's way of communicating a summary of all of the problems that they are managing for a patient. But as a coder, we have specific coding instructions and documentation instructions that say we cannot use the problem list unless there's some notation from the provider that states what you did to manage the problem. So here's an example of a problem list that we can use. The physician documents HIV status, HIV positive, stable on meds, diabetes with neuropathy, meds adjusted, congestive heart failure, compensated, COPD test ordered, hypertension is uncontrolled, and hyperlipidemia is stable on meds. If the chart note just states the conditions with no statement of how those are being managed, as a coder, we cannot utilize these conditions, although you may be treating the conditions. So it's very important as a provider that you clearly document the status of the medical problems that you're managing. All right, I'm going to go active versus history. We only got a couple of minutes left. For the purposes of HIV and AIDS care, active translates to the current state of that condition. So if the physician documents active AIDS HIV infection, we're going to code it as 042. Or if the documentation states that the patient is active HIV positive, we're going to code it as V08. So it's very, very important that the documentation is very clear, because as a coder, we only go by what's documented in the record as our foundation for assigning codes to a record. As we saw in the diagnosis portion, there are no codes for history of. It's either HIV or AIDS infection or HIV positive. So it's clear that if the doctor documents appropriately, we will be able to assign the most appropriate codes for those services. E&M wrap-up, HIV testing or preventive care. If it's a well visit, if it's a new patient well visit, you would report one of the well visit codes for a new patient. If it's an established patient well visit, you would use one of the established patient codes to report the established patient well visit service. If it's a counseling without any testing, you would use one of the counseling codes or follow up with your state Medicaid agency, because again, if they tell you to utilize one of the E&M service codes in place of counseling, then those are going to be the instructions that you should be following in accordance with your Medicaid agencies. HIV pre-test with testing and preventive care. So you report the applicable code with the HIV test modifier. Same thing with the counseling without preventive care. Your point of care testing, so you would report the appropriate CPT code for the HIV test performed with the modifier if that's the guidance from your local Medicaid agency. Point of care testing without point of care testing that includes counseling without a preventive. Again, you report the test that's performed with your applicable modifiers. We didn't really talk about confirmatory testing, so I'm going to skip past that. But here are the codes that reflects your HIV testing. 86701 was the code for the rapid point of care test. This slide just gives you an overview of if the services for an HIV 1 and 2, the coding guidelines state that you should use 87389. But again, your local Medicaid agency or your insurance carriers that you participate in, ultimately they are the final source that drives your reimbursement. So these are just coding guidelines, gives you your foundation. You should check with your local insurance carrier, your local Medicaid agency for the appropriate guidance. These are some diagnosis coding tips, and because we're short on time, I'm not going to go over those in detail. I wanted to bring to your attention, we spoke about this, but I put it on the slide for you. As a coder, if a patient's chart states suspected, suspicion of, possible, likely, rule out, questionable, consistent with, presumed to be, or appears, we're not going to code it because that is not consistent with any of the coding guidelines that are in the coding books. We'll code the presenting complaint. So if the patient comes in and they have muscle aches, rash, or ulcers, those are going to be the diagnoses that we're going to report for a case where the terminology here is documented in the record. We spoke about the sequencing. The last slide I wanted to get to, in PowerPoint Series 3, we spoke about ICD-10, and we were all excited and gung-ho that ICD-10 was going to be implemented. And now there's been some changes. The new ruling is that ICD-10 will be implemented on October the 1st, 2015 instead of October the 1st, 2014. I strongly encourage you to continue all of the activities that you've been doing to prepare for ICD-10 because at any moment's notice, this could change, but as of right now, we're moving to ICD-10 next year. I threw together this scenario for you. Patient returns for their test results. They also request prescription refills for hypertension. The physician spends 15 minutes counseling the patient. The education literature was distributed. The physician also checks the blood pressure and notes that it's unusually high. The dosage on the meds are increased, prescriptions are given, and the patient a referral is made to a nutritionist. The final documentation is that the physician documents that it was an expanded problem-focused history with moderate medical decision-making. And so in this encounter, the level is a little high, and the reason why is because, I put a slide that shows you the corresponding I-9 codes against the I-10 codes. So this is a patient that has the AIDS condition. 042 is the I-9 code. Counseling was done, V65.44. The patient has hypertension, V01.9, and V68.1 is for prescription refill. And these codes are the corresponding ICD-10 codes for this I-9 encounter. So this slide just talks to you about why documentation is important. Medical necessity, E&M code selection, diagnoses, procedures, and modifier usage. Documentation inaccuracies result in payment recovery and heavy sanctions by the Office of the Medicaid Inspector General. You don't want to be a provider that's placed on a sanction or an excluded list. So we encourage providers and coding to work together to make sure that the encounters are appropriately coded. The coders can also provide guidance and suggestions on the type of documentation that's needed in order to assist with ensuring that the diagnoses are correct. Documentation is important. It helps with complete coding and accurate reimbursement. And here are the resources that I told you about. The Centers for Medicare and Medicaid Services, the Food and Drug Administration, the AMA, NCHS, and CDC. These are the coding resources, as well as other resources that were used. And now I'm going to turn the presentation back over to Michael. Thank you very much, everyone.
Thank you, everyone, for your participation in today's webinar. If you have additional questions for Stacy, feel free to raise your hand, and we will address those questions for you, or type your question into the QA box below. Okay. I would like to remind folks a few items that Health HIV does have a program called Fiscal Health, which provides capacity building services to Ryan White grantees. Please feel free to contact Julio Fonseca at julio@healthhiv.org. Additionally, we will have another webinar series coming up next Thursday, May 15th, 2014, from 1 to 2:30 p.m. Eastern Time. Let's build an indirect rate together. This is a second in a series of 2 webinars, which can now be found on the Health HIV website. I'd like to thank everyone again for your time on our webinar today. If you have questions, please feel free to email me at michael@healthhiv.org. The web presentation slide deck as well as the video recording of the slide deck will be available on Health HIV's website within 24 hours. At the conclusion of today's webinar, you'll be provided with a brief survey evaluating the quality of the webinar that was provided to you today. If you could please complete that survey, that would be greatly appreciated. With no other questions on the floor, I'd like to thank Stacy for her time today and wish you all a very happy weekend. Thank you.